This is the video of laparoscopic Heller's cardiomyotomy for achalasia cardia type 2. Endoscopy and barium is the basic investigations to be done, and apart from that we can go for a CT and a manometry. Manometry is gold standard investigations for achalasia cardia. This patient had a type 2 achalasia cardia. The patient is in general anesthesia and with the abducted leg with the head and up. So, I am standing between the leg and then I am making a 5 port, one camera port 10 mm, just 4 finger breadth above the level of umbilicus, and then subxiphoid for liver retraction, right and left pararectus for working, and left lateral for retraction of stomach. This patient had an accessory hepatic duct, hepatic artery. Now you can see how much above the camera is there, above the umbilicus. This is the team setup, camera surgeon assisting and staff nurse for retracting the liver. Since the patient had accessory hepatic artery and CT wise confirmed, and I am going to preserve this artery. So, main purpose of doing CT is this find out this any abnormal anatomy, and other than that any thickening of esophagus is there or not, to rule out the pseudoachalasia. All patient I put a Riles tube before starting the cases, and previous day night I put a Riles tube and then I wash out the lower esophagus, and approach is same like lateral approach of mobilizing the esophagus, and fundoplication series all the it will be discussed it nicely. So, I open the gastrohepatic omentum and then I go to the crest level, only the peritoneum I excise first, then I open the phrenoesophageal membrane. So, that is the left phrenic inferior phrenic artery, that is a vessel is preserved, that is the fundus bare area of the fundus, and always this type of vessel will be hindrance for exposure of the lower esophagus OG junction. But we could able to manage. It required some experienced camera surgeon to sew in a very narrow space, and so that is the crest. I am taking the fat attachment to the crest. I am not putting any extra instrument to lift the vessel, is no need, and with the left hand itself we can retract and then we can dissect the space. And since I am planning for a 2-pay fundoplication, I am doing a retroesophageal dissection, and my preference is 2-pay posterior 180-degree fundoplication after the Heller's myotomy. We believe in GEM it is a good reflex control, and many centers they are doing a DOR fundoplication. In that case is no need to do the posterior dissection of esophagus. So, I am entering the hiatus. Once it enter, immediately the first structure is the post vagus. Now you can see the post vagus now course is here, and it's easy to injure. No, that's why when you are entering the hiatus, you have to see the post vagus. So that is the phrenoesophageal membrane. I lifted the post esophagus with my left hand along with the esophagus. I am dividing the phrenoesophageal membrane. So I am going to dissect the esophagus completely all around, and not on posterior side, and initially I dissect the retroesophageal on the just above the OG junction. I am not dissecting entire posterior mediastinal dissection on as like in fundoplication. So, we are concentrating the anterior dissection, how much length of myotomy is required. So, we are concentrating the anterior dissection now. So, now this is the phrenoesophageal membrane, again I am dividing, I am checking the anterovagus. You can see it is lying on the crest. So, that is the left pillar of right crest, anterovagus and phrenoesophageal membrane. Phrenoesophageal is a thick membrane, white color membrane, otherwise called inferior diaphragmatic fascia. So, it is like a cap. So, in the diaphragm there is a hiatus is there, and through the opening the esophagus is entering the abdomen, so that the opening will be there above and below. So, above also one membrane is covering that opening esophagus and the hiatus opening, that is called superior diaphragmatic fascia. Inferiorly it is called phrenoesophageal membrane or inferior diaphragmatic fascia. So, I am again I am identifying the phrenoesophageal, I am dividing the phrenoesophageal membrane. Once you divide completely, then only you can tell that esophagus is mobilized completely. So, since I am doing a post fundoplication, I am doing this much mobilization, otherwise is no need. But in case of sigmoid esophagus, even a mild sigmoid or some cases the curvature of esophagus will be on the right side or left side, and you have to do the mediastinal dissection and you have to straighten the esophagus. That is very, very important. That will relieve the dysphagia. So, all the before myotomy, the esophagus, lower esophagus should be straightened. That will be with the barium swallow. You can able to identify how much curved of the esophagus. Mostly will be on the right side. Some patient will be left side. So, the usually during surgery, the barium swallow will be on the lobby. So, we used to see whether which side esophagus to be straightened. So, the mediastinal dissection of esophagus is very much required. So, now the is mobilized completely all around on the lower esophagus. I am using harmonic HD probe. So, the life of the probe is 10 hours and ergonomically designed handle. So, I'm all this thing I'm using with the hand switch, hand control harmonic action. I'm not using the foot pedal. So that the advantage is I stand with the two leg comfortably. Second thing, it's a very ergonomic handle, so easy to operate, and the sharp tip will be helpful for fine dissection. And then non-sticky material lower blade is done so that the tissue will not stuck to the lower blade. So, I am doing a mediastinal dissection. Mostly I am doing on the right side in most of the cases, that is the right pleura is separated from the esophagus. So, that in that case esophagus idea is to straighten the esophagus. So, now I am starting the anterior dissection. Always when you are doing anterior dissection, you have to take care of anterior vagus. Identify the anterior vagus first before division of any small tubular structure or vessel or anything. So, that is the anterior vagus now. So, now it's confirmed the course. Now, I am dividing the vessel. Don't divide any vessel or any other structure before identifying the anterior vagus now in an anterior dissection. So, these are all the loose areolar tissue. My way of doing is 9 centimeter on the esophagus myotomy length, 2 centimeter on the stomach. So, that means 11 centimeter. Most of the time it will be more than 9 centimeter on the esophagus. That means 11 centimeter on the esophagus, 2 centimeter on the stomach side. So, 13 centimeter myotomy I used to do. In case of recurrent achalasia, redo Heller's cardiomyotomy, it will come in later series. In that case, I do 3 centimeter of myotomy in a cardiac side, in a stomach side. So, that is a recommended one. And the Patty series, this is the maximum achalasia cardia done in one surgeon. And so, his series he clearly mentioned recurrent achalasia, it's required 3 centimeter of gastric myotomy. So, now this is the step is to mobilize the anterior vagus. So, the pad of fat on the OG junction is mobilized. You can see I am taking out the pad of fat completely. When I take this pad of fat, the peritoneal covering of the esophagus also will be separated from the esophagus. So, in that case, what happened? I could see the bared muscle, that is a longitudinal muscle. I could see very well. There is no covering of the longitudinal muscle will be there when I am dissecting the pad of fat on the anterior vagus now. That is one way it is helpful to start the myotomy easily. If you are not doing this one, and then if you keep the peritoneal covering of the esophagus, and then the myotomy will go on the peritoneum covering only, it is not on the esophageal wall. So, that is why. So, now you can able to appreciate the coverage of the esophagus. So, now here it is a lower is the muscle is exposed, upper esophagus the covering is still there. So, I am not holding the vagus, I am holding the facial covering of the vagus, so that vagal now paraxia will not be there. So, now this is the esophagus without peritoneal covering, that is a with peritoneal. Now, you can see the longitudinal muscle is very well nicely seen. That peritoneal covering will interference during your myotomy. So, always how much myotomy is required, you have to take out this peritoneum. So, this way it will be helpful. If you start from pad of fat, OG junction pad of fat and anterior vagus, you can able to separate the peritoneum easily. If you start from upper esophagus, you will injure the esophagus. So, slowly I am coming on the right side, and both side it is connected now. During this time, the vagal anterovagal branch on OG junction and the upper part of the lesser curvature will be divided. I am not dividing the muscle with the harmonic scalpel, I am just separating the vagus and the peritoneal covering with the harmonic scalpel. Most of the time, what I observe, the esophagus, the longitudinal muscle has a lot of blood supply. So, when you are dividing the longitudinal muscle, I use the separate the longitudinal muscle, I used to do the cautery, monopolar cautery or a bipolar. So, longitudinal muscle will not be divided, it is a separated. And then circular muscle fiber, there is no vessel. So, I used to just divide the circular muscle fiber with the instrument only. So, now I dissected around 2-3 centimeter length of cardia, length of the stomach, the peritoneal covering is dissected up to 2-3 centimeter on the stomach side, and esophagus side also it is well dissected. It look like little bit curvature on this other side, that is also straightened. So, now I am going to start the myotomy. Before starting myotomy, this type of any correction, post dissection is unnecessary, is no need, and if I want to close this hiatus, I have to close, and then the fundus mobilization also to be done. Once the myotomy is done and the esophagus should not be retracted, that is the idea, and all the other work you have to do before the myotomy. After myotomy, if you retract the esophagus or pull the esophagus, no, the chance of injury to the mucosa will be higher. So, that is why we do not do anything after myotomy. So, I started mobilizing the fundus. Is only 1 or 2 vessels will be divided, short gastric. It is very short mobilization of the fundus. It is not like a greater curvature separation. And it is so it is not Nissen, it is only 2 pi. The post coverage of fundoplication is enough. So, now I am holding the post wall. So, that is the first vessel is being divided now. So, that is the second vessel. So, only 2 vessels. So, this may be the post gastric artery, only one short gastric is divided apart from the post gastric artery. The coagulation mode of harmonic is very useful, it will coagulate nicely and then it will cut. Always retract the stomach with holding the post wall nicely, expose the area and hold and divide the structure. Since you are having an energy device in your hand, it does not mean that you can divide anything. If a proper exposure and you have to hold the vessel perpendicular to the blade, it is not there and then it will bleed. So, that is the inferior phrenic vessel is totally preserved. It is supplying the left part of the hemidiaphragm. So, now I am checking the adequacy of the fundal mobilization by suicide maneuver. So, it is even a Nissen can be done, I am planning only for a 2 pi. So, I keep a 2 gauze piece and then both hand I am using a Maryland forceps, both hand Maryland forceps, and the starting point will be the 2 centimeter above the level of OG junction. The aim is first to separate the longitudinal muscle, and if you required you can apply monopolar cautery, and during this time I ask the anesthetist to pull out the Ryle's tube. They keep the Ryle's tube in the midpoint of esophagus. I do not want to Ryle's tube when I am doing the myotomy. No bougie Ryle's tube is kept during the myotomy. So, now I could able to see the circular muscle fiber, and you can see the Maryland dissector. There is a 2 type of Maryland is there, long and short tip. You have to select the short and blunt tip. So, this is the circular muscle of esophagus, that is the mucosa of the esophagus. So, both hand Maryland and the right hand is connected to the monopolar cautery. So, I am going in the circle between the mucosa and the circular muscle, I am trying to separate the circular muscle. So, if you start at the OG junction, so what happened, that is a oblique muscle fiber, so it will make you confused. So, always The normal longitudinal circular muscle fiber is about 2 centimeter above the level of esophagus. It will be nicely seen, and then you can start from there, and that is the area the muscle will be thickened. The circular muscle will be thickened, and the lower esophagus foot stasis, and then long time contraction, it will be thickened. Now you can see I am using the scissor designed by Professor Palnivel sir. It is a modified sugar baker scissor. This is just like a monopolar cautery scissor, straight scissor, but the lower blade is protected with the insulation all around, and then base and then front, so that cautery will not go to the mucosa. So the anterior longitudinal and circular muscle is divided with the cautery without damaging the mucosa. Cautery will not go to the mucosa. That is the advantage. And then the blunt tip, I can able to separate the mucosa from the circular and longitudinal muscle with the scissor itself, modified sugar baker scissor itself, and then cut. So now I am using a Maryland. Always Maryland is better. Then you can use this scissor to cut. The Home Surgical Company is manufacturing this scissor. Initially 10 mm, and then they manufacture it 5 mm. And once you learn other technique, nowadays I am not using this scissor. Maybe in future videos you can see how I am doing a myotomy. But this will give a very simple, even a very thick muscle, it will be cut nicely. There will not be any bleeding. And normally we are expecting a vessel in the circular muscle once in 3 to 4 centimeter distance. So now I am going in the mediastinum. I am now going in the mediastinum. So usually I go around 9 to 11 mm, 11 centimeter on the esophagus side. And all my fundoplication series, you can see I am tying the tape, cotton tape around the OG junction. I pull the esophagus to dissect mediastinal, the mediastinal portion of esophagus dissection. But here already OG junction is contracted, so I am not using any tape. I am just holding the stomach and retracting the esophagus. So here some cautery is not working, some bleeding is there, and don't worry about the bleeding. Keep a gauze piece, wait for some time. If you try to coagulate the bleeding, you may injure the mucosa. The cautery effect will go to the mucosa, and then it later on will produce some delayed perforation. So that's why mucosal side no cautery is applied. Just keep a gauze piece. So you can see one gauze piece is kept inside. I kept another gauze piece. I am coming on the OG junction. Here I cannot separate the circular and longitudinal muscle. Just I am holding the longitudinal muscle. You can say I am just like a I just pull both the end. So automatically muscle will get separated. So now I am coming on the cardiac side. I just make a cautery mark up to what level I have to come. I just made a cautery mark like this, and then up to that level I dissected the muscle fiber. When you are doing a myotomy, everyone the mind is mucosal injury. That is the reason many surgeons they send their patient for POEM, peroral endoscopic myotomy. And so the idea of this Heller cardiomyotomy series is that fear is no need for that fear. Esophageal, all of you know that the strongest layer of layer in esophagus is the mucosal layer. So if you are do a correct way, correctly, if you are doing it, mucosal injury is very difficult, very much unlikely. So, and you can see all the time the curved dissector, the curved portion, the tip of the curve is facing upwards. I am not facing downwards. So that is the first key. All the time you have to keep it upwards. Second thing, when you are doing myotomy on the gastric side, and just hold the muscle fiber and then pull like this, and then don't do like a dissecting, keeping the curve down, and then don't do like a dissector, like a Maryland calyx dissection. You should not dissect anything, do not dissect the muscle. These are all very thin muscle. If you hold the hold the muscle on either side, if you pull like this, so it will be separated. So that is the key. Using a Maryland, I am not dissecting. I am not keeping the curved tip of Maryland down and then I am dissecting. It is just only the separation of muscle. It is not a dissection of the muscle. So no need for fear of injury, and I am going to put 10 different scenario of the Achalasia cardia. Definitely it will be helpful. See the myotomy, how I am doing it in 10 cases. That will be give good confidence to you. So you can do a Heller's cardiomyotomy without any mucosal injury. And why it is called gold standard in Achalasia cardia? and here myotomy is done. Now you can see the bleeding is stopped automatically. Myotomy is done, and then the reflex also controlled by fundoplication. So both the work done in single surgery is not like in a poem. So reflex incidence is high, so that will be avoided. So one stage both problem is solved. So now I am doing air leak test. In air leak test, I am not introducing the endoscopy. I am just put the air through the Ryle's tube. The Ryle's tube may be in the mid esophagus, but anyway air will come. You can see air leak test is done. Now I ask the anesthetist to push the Ryle tube slowly, very carefully, seeing the monitor. Anesthetist has to see the monitor, and then they push the tube centimeter by centimeter. It is not forceful introduction of Ryle's tube. Now Ryle tube is inside, and this is the one step. As I told you before, it should be done before myotomy. Now you can see how much esophagus is retracted, and then it is strained to the mucosa. Your instrument accidentally slip and then injure the mucosa. So that's why this step to be done before myotomy. Even if you leave it, nothing will happen. And if you're doing it also, one of the live surgery in Thane, Mumbai, on live surgery time, no, Thane Surgical Society live surgery. The question was why you are doing a suturing of the crus. Already patient is in dysphagia, you are making dysphagia again. That was the question. But this will not produce dysphagia. This will, for a large defect opening is there. This will prevent the reflux control. That's why. So now usually there is no limit. No, there is no limit. You can sometimes I used to keep a tape and then I measure the tape. And when you are doing a myotomy, your mind says, okay, we'll do further some more like. But it is already 2 centimeter is crossed. Even 1.5 centimeter on cardiac side is also enough. But recommendation is 2 centimeter. In a recurrent recurrent myotomy, you have to go for 3 centimeter. Now you can see very lax fundus. I am taking the fundus between the esophagus and the vagus now, anterior vagus now, so that vagus will not come in my way when I am doing a fundoplication. This is the excess fat. I am just excising it. So during immobilization of fundus, we don't go close to the fundus. So now we are going close to the fundus. I am excising all the excess fat. So now this is a posterior tube. Now you can see the entire anterior mucosa is exposed. It is a projecting, sprouting of mucosa, projecting or ballooning of mucosa. Otherwise, not ballooning, it is a mucosal bulge is seen. So that means your myotomy is adequate, and it's anterior 180-degree myotomy. It's like not only one slit, it is a anterior full 180-degree is exposed, and then that excised longitudinal and circular muscle portion, no, the muscle wall is sutured to the posterior wall of the fundus on the right side. So this is the post wall of fundus. I am using 2-0 ethibond, that is a polyester suture, ethibond suture, non-absorbable suture. It comes with 2 needle, 2 end is there. So a very small needle, 30 centimeters, so 30 mm needle. So it is easy to use in this step. So it is called posterior 180-degree two-pay fundoplication. The posterior turn 3 suture. No, usually 3 suture is required around 1 centimeter, 1 or 1. So 3 to 4 3 centimeter length of two-pay fundoplication. So this side 3 suture is done. So left side also divided muscle is there. You can see how much mucosa exposed, and the divided thick muscle. I am taking a suture on the anterior fundus, anterior wall of fundus. The idea is this will keep the muscle away. So the muscle will not get reunion of the muscle will not be there, and effective reflex control is reported with the post 180-degree. So that's why this one fundoplication also many surgeons they are doing a posterior two-pay. modified 2-pay 270-degree fundoplication. Even fundoplication we are not doing anterior fundoplication, no. So, always post, even though studies shows equal effect, but we are not believing, we are doing a Nissen or 2-pay modified 2-pay. So, here also I am doing a 2-pay, there is a anterior positive 180-degree, so that the reflex control will be good. And I allow the clear liquids on next day, liquid diet on after 24 hours, and third day I used to discharge the patient. Even I can discharge on the next day or one day after second day, but my way of doing it, third post-operative day I discharge the patient with semi-solid diet. So, now you can see the antervagus is not injured, and myotomy portion and stomach, my gastric side myotomy also. And so, this will this patient had both myotomy done with the post fundoplication done. Thank you.